what I'd like to do for the next 35 minutes or so is open it up for discussion among all of you. There may be comments that you want to make to each other or ask questions, or I've been jotting down a bunch of notes that I can come up with, but I would open it up to begin with. Are there any comments that any one of you want to make somebody else about the things you made or questions? And if it's okay with everybody, I'm going to switch to first names now since a number of us have first names anyway. So, Pat.
Yeah, I would love to address cost because I almost lost my house during this. And I was a working single parent. I almost lost my house. And so, but because of that, and because of my background, I learned how to cut costs. I don't think anybody but families are doing that, to your point. So I learned how to make my own sterile water, saving $158 a week. I learned how to clean my syringes and reuse them. I learned how to do TPN myself, so I didn't have to have a public health care nurse. I did blood draws, and we got somebody to come and take them. We did trach cleaning. We kept our trach after we cleaned it for 5 days instead of throwing it away like they do in the adult system, which is why we now have a back order on trachs. But there are so many things that we learned, and I learned from my pediatric docs and the families that I work with. We share stuff. We share medical supplies because we have leftover and our child gets better, but we have leftover stuff. We call one another and we go, can we share? The other important critical thing that's missing in the state is home care nurses. I don't need to go to the ER. If you looked at her records, my care at home was better just because my nurse knew her, knew how to do all these things. She was a critical care nurse, all 12 that we had, and they make half of the money that a nurse in a hospital makes. It saves us the long drive, the care and all the craziness. That's a way to save money. If we can give them more money and keep our kids at home, it also keeps us healthier. And we know how to cut costs. Trust me, if you could get together with a bunch of us families where we're trading supplies and trading this and doing that and sharing best practices, we know how to do it. Somebody has to listen to us. We're with you on that.
Thank you. And please, everybody in the audience, don't take that as an endorsement to start cleaning your own trachs necessarily. But I think the reality of what you're mentioning is important, that there are things that parents, family members start to do. And it brings up one of the issues, and Wendy, I think you were alluding at, Mayo's this great system and it's got tons of stuff in Rochester, but not everybody wants to live in Rochester all the time. For those of you that are in the audience that don't know, Minnesota has a finite number of significant metropolitan areas. We've got the Twin Cities metropolitan area. We have Rochester, we have Duluth, we have St. Cloud, and I think people would include maybe Mankato. Beyond that, the state becomes very rural. And so when you're, Pat, you mentioned about home care nurses. Well, there's a horrible shortage of home care nurses everywhere.
Yep.
If you then try and find them in outstate area, it's really difficult. Nancy, I think you were talking about how great it is having med-peds physicians who are ideal to take on this care, but they're mostly located in the metropolitan areas. You go out into the outstate areas, from what I've been told, most primary care is provided by family practitioners and a lot of it by nurse practitioners. So the med-peds are not readily available. So I think this issue of how you provide any of this care outstate also, not just what may be available in metropolitan is important. Thoughts about that from anybody?
I worry that whatever solution we build today may not be sufficient, as you mentioned, with the shortages, which we're seeing people living in the hospital for months because we can't get the home health care that we need, even in the metropolitan areas. So I think as we think about the solutions, we need to think about what the COVID pandemic has done to our home health shortage right now and see where those predictions are in the future. And I don't know who owns that data of what the prediction for those shortages will be, but it's probably that plus a margin of error of 10 to 20% is my guess. Because I only see that for Minnesota and other rural areas getting worse in the future rather than better. So I think as we think about these solutions, we need to really dig down into the predictions of where that's going to be.
I would add, I think it's very important to have all the experts involved. But the point you guys are all making is that having people available locally to help families, to have medical daycare, to have family practice docs that are comfortable taking care of children or adults with rare disorders. We have to find a way as specialists to partner with those people and support them. Whether or not that's virtually, I mean, a lot has happened in virtual medicine. I've seen, virtual people consult on someone in the emergency room and walk them through intubation. It's amazing what you can do virtually, right? So how can we, I don't have the answer to this, but how can we set up systems of care so we leverage experts and do, teach the local person and partner and have ways to communicate? I mean, we have to have extenders for our experts and extenders for families that have been through this to teach other families and to create deeper partnerships throughout the system, because we have ignored people in rural areas.
And just to mention, at the end of the afternoon, Dr. Barr is going to talk a little bit about an exciting project coming up. It's going to help individual adult clinicians feel more comfortable with an ECHO project that we're both involved in. So
that was the name of it I was trying to remember.
Yes.
Okay, yeah.
So you're going to hear more about it.
Okay.
Other thoughts from people?
So I think of, problems through a parable that has really informed work that I've done in the nonprofit sector and advocacy. And that's, there was a couple that was walking next to a river and they saw a child in the river. They fished the child out. And then another child came down and they fished that child out. And they kept fishing children out of the river. And at one point, then they decided, well, why are children falling into the river in the first place, right? And I think that's important here because I think it's important that we figure out in the system we are in, how do we help get more children out of the river, right? How we can do better. But why are they there in the first place? And I think they're there because we don't treat healthcare as a human right, right? And so what can we do? What conversations can we have with the decision makers who have determined that you get healthcare if you have the money? And the only time we step in to help you is if you've spent all of your money and all your assets down, then we'll come in and give what we can, right? And even then we'll kind of limit it because of the cost, right? And so I think, I think that's really important to bring to bear here, because I fear that if we continue to just kind of focus again on how do we get these children we see out of the river, we're going to miss an opportunity as we're coming together, learning these lessons that we've learned from COVID-19 at we can move fast. We can make big changes when we identify a threat and come together and say, yes, this is all an issue. So now that we have these tables here, how do we kind of really leverage that to ask these bigger questions to kind of push us to where I think we all have at this table, and I think a lot of folks believe we need to go.
When you talk about education, the Pacers Center came up with a program, 20 years ago, called Parents and Residents Together. And they go to the U. We have the person that works for me, goes to the U, and she's amazing. She's actually a doctor herself, and she teaches them about families that have disabilities. They have a program at the U where she matches those families up with the residents so that they can get an inside view. Now it's Zoom. It used to be they came to our house. 2 medical students came to us and loved that idea and said, we got an idea. They had an unbelievable program put together and said, as first and second year medical students, we want to know what these families are like. So they started, and it's called Gopher Buddies. And so it's been 4 years. I've had 4 Gopher Buddies, and it's a 1-year program where they can go to us, they can be with us and do with us in any aspect of our life, from doctor's appointments to church to games to whatever. And they put this program together. Every year, I go and talk to them as they start the program. We have 36, I'm sorry, but I say kids right now, that are medical students. On top of what they're doing, are matched with people like us, families like us. They're going to get it.
Yeah, they are.
They're going to get it.
So a number of you talked about the difficulty with communications and transitions within systems. So we've got representatives from 1, 2, 3, 4 major systems in this panel, with CentraCare, with Mayo, with the Medicaid system, and you can also talk about your particulate, although particulates with Lima and Lima systems. Different areas around the state. So if you've got a patient, Wendy, let's say we're doing the primary care, and you got a patient and they're moving up to St. Cloud, and they need to establish their care, or they're going to be moving into the Twin Cities. What can any of you do within your systems, or what do you need to be able to do within your systems to make that communication better, assuming for a minute that you're not all on the same EMR?
I can tell you what it looks like right now. So if I want to send somebody to St. Cloud or Duluth, I reach out to somebody who's a little more senior to me, who's lived in Minnesota longer, and I say, do you know anyone there? Mm-hmm. And if you do, who would you recommend? And then I Google and I call that main number, and then I start working through the phone tree. Very inefficient. There's got to be a better way to do that. And then if I do get through the phone tree, that person is probably in clinic and probably with a patient who deserves their time. And so to step away from that is hard. And so it can take weeks to make a connection to ensure that somebody can be received if I want to send them, or if that's the appropriate place for them. And so how do we, like you said, I do telehealth, I've done a telehealth visit to Turkey. If I can do an oncology consult in Turkey, why can't I get somebody to a primary care physician in Duluth, Minnesota? There's got to be a way to do it through our technological systems here. And so I am constantly surprised that the systems don't talk to each other. There's no central compendium of information, of providers, of interested people that would receive these patients, to my knowledge, at least for being here for 2 years in the state of Minnesota. I don't know where that exists, if it does. So if it exists, please enlighten me. But that is how a lot of my day-to-day business goes on my administrative off time, et cetera, et cetera. So it's completely inefficient. I hope that the people that I send them to are high quality. How do we assess that? I don't know. But there is very haphazard right now. So how do we make our systems work better? How do we get a central system or a registry or compendium of information that we can all work together towards, so that we know we're all working with the same place? Like, is there quality metrics? Can we somehow assess those?
And I will just say that when I was in practice, I kept a list of the clinicians that I had heard and had were willing to take on patients, and I guarded it closely. I would share it with my office clinic colleagues, but no one else, because I was afraid they would all get filled out.
Yeah, you don't want to saturate them. Right. You want to save them for your own patients.
And I will put a plug in for a minute. The only repository of that information you're talking about, it's a tiny one so far. We're trying to build through the Chloe Barnes Rare Disease Advisory Council for the state. We're trying to develop a registry of both primary and specialty care clinicians who are willing to take on those patients, but it's a slow process. Other comments?
So I think that's what, I have trouble getting people from Shoreview to Maple Grove, okay? Let alone to like Duluth or somewhere else in the state. And that would be just, if I had any patient, I would I don't know, I mean, and I think it part of that, I think, is incumbent on each of the systems. So I only know my own, I look at sort of my bio, very generic, I had to change the picture because it looked horrible. Now it looks better, I think. And it sort of says things like not taking new patients, internal medicine, pediatrics, travel medicine or whatever. I'm like, travel medicine, who knew? I didn't. So it is, I think that just the data available, even for patients to look for a physician, is, I think, inadequate. And, and this is something we're actively working on. We have a whole digital team that looks at this. But it seems to me, just getting to your point about, when the pandemic started, I was going from doing no virtual care to virtual care in the span of 24 hours. We just hit the gas. Now, was that perfect? No, that was actually not perfect. But it wasn't horrible, by the way. And, by, 72 hours, a week later, it's working pretty good. So I think we have the ability to sort of do that. And that's a simple thing. And I think a compendium like that, I was thinking that as well, to say, who is in that? Because right now I actually am on one of those lists somewhere. I know I am because I say, well, I'm not taking new patients. Oh, but you have to. I really, my two MedPeds partners that I work with too are also, there's not enough MedPeds people in primary care to do that work. I'll just lay that out there right now. It's going to have to be family medicine. Mm-hmm. There you go. Mm-hmm. Because MedPeds docs are going into hospital medicine or subspecialty medicine unless they need to stop doing that because there's something else better out there. So to have that resource available on our websites even or on our data, there's got to be an electronic way to figure it out. So you can say, okay, this person's going to Shoreview. Who's in Shoreview? Oh, Dr. Elting-Ballard at a line of Shoreview. Okay, MedPeds, we can do that. I don't know anything about him. He's got 5 stars. I think I have 4.9. His comments look pretty good, and there's other data out there available. I'm going to roll the dice, or I'm going to pick up the phone and talk to that person. Can I do that?
Is there anything nationally going on, like with the American Academy of Pediatrics and Family Practice? Can we get them to
That's a good question.
Coordinate and create a certification?
There's not anything that I'm aware of. I think the fact that 500 people registered, almost 500 from around 40 states, shows there's a lot of interest and probably not an immense amount of great ways to do it. Again, there's a whole lot of data out there in literature about transitioning children with special healthcare needs, those ones with 1 or 2 problems. I mean, all the things that the website that you mentioned earlier, Nancy, and others, there's lots of stuff laid out how you do this process. And then there's a few articles that are written, like the one that Pat and I wrote about transitioning these complex patients. But I know when I go to conferences, everybody's saying, what do you do? How are you doing this? What are you doing? No one really knows it well right now.
Yeah, I agree.
I'm going to shift a little bit in the direction of the conversation, but one of the things we haven't talked about is even just the data transfer. Most of the state is on Epic, and yet that doesn't mean much. I see patients from all over the state, from probably all the systems in the state, and to get into records is horrid.
Can be challenging.
And there's barriers that even if somebody had told me you're going to see this patient who's got complex care needs, my system won't allow me to actually click into that chart till that patient is sitting in my office.
That's right. Yeah.
And it's ridiculous for thinking you're going to actually be prepared to talk to that patient. And then, you'll get raw data, but could you get a summary that actually says, here's the latest information about this particular patient? That's a dream world to me.
I think go ahead.
No, go ahead.
I think one of the, kind of piggybacking off that and something that you said, one of the issues with these complex patients is the payer system. And you said, how do we make this better? So, unless the MedPeds people find something better, well, how do we make this better so that they want to do that primary care piece? And the other point of this is the way that the reimbursement system is set up now, if we do all that digging 24 hours before our visit, it's not compensated. Right. And so to look through 20 years of a complex medical chart in an hour or even a 2-hour visit is insufficient. And so there's a lot of uncompensated time. So how do we make that better for the people so that they want to do the work and they get high quality care and they're compensated for it from the system? Because I think those are all major issues.
So it's interesting, I'm going to go out on the limb of, I may not know exactly what I'm talking about. Medicare now will reimburse us for complex care. It has to be done on the same day. Mm-hmm. But so you could theoretically on that day, people do this. So I know we do. You start, I've done it. You start and you review those records, right? Oh, this person's there's not an organ system that's functional, right? And a med list like this, assuming I can get them. That's a different issue. I review all those and I spend half an hour doing that. I see the patient for half an hour and then I have to re-review it because they tell me new things. That's reimbursable work, and it's not That's actually some serious RVUs. So it does happen. It can be done. Medicare's doing it. I don't know if the private payers are doing it. I don't think so. I don't think the commercial payers are doing that. But Medicare is, for what that's worth.
They're moving in that direction. There's a few of them that are starting to use that same system. And so there is, but yeah, you do it the night before.
Yeah, you can't do
And
that.
there's no compensation.
That doesn't count unless you get a
Building that into a clinic flow where you need
Right.
3 hours is probably a
Well,
non-starter
and there's
for
not
most
an
systems.
internist would never, I mean, forget it. I'm on a straight 20-minute schedule. Most internists, because I'm a med peds doc, most internists are on 25-minute schedules. And it's like, there's not, and not only that is a lot of internists have no idea what these, they look at this patient and be like, I don't want to take care of that patient. So that I have no can do. So I think it's just challenging and there's no time.
So you've got 4 systems here, because I'm including you with Medicaid. You got 4 different systems. You got people at different levels here of seniority, leadership, or whatever. Have you had discussions with your organizations about changing some of the compensation issues, compensating for this? What was the response? What would keep you from it? If somebody came to the state, Nate, and said, I want to take care of these kids or these adults, but I'm not getting compensated to do it. What can we do different? Answer, thoughts from any of you.
So I've actually had to design a compensation system. So yes, we've tried to do this. It's not easy, and providers, anytime you start talking about compensation, they go right to that reptilian brain.
Oh, absolutely.
And so getting something to change is really a challenge. And yet, if you can get the recognition that we can share risk. We can share how, take the risk out of it for a provider who is trying to do this type of work and allow them to take that longer time period they need to manage these patients and yet still get paid in a realm that's, reasonable. You're going to get the pushback from those who are wanting to be super producers and, want to be on the RVU system saying, well, you're taking money from me. There's ways of dealing with that. There's the bigger the system is, the bigger the pocket is, the easier it is to do. And so an independent clinic becomes a challenge to do that type of thing. But in a bigger system, it's a matter of creativity.
We, that's really well said. We have in Alina, we have I don't know if other systems are doing this, we have a complex care for seniors program. So, and they're usually Medicare Advantage patients, they have to qualify. But it is geriatricians who go to patients' homes. They're partnered with care coordinators, nurses, social workers. There's a team of people, they're all on salary, right? I should be careful when I say there's like 500 people out there. I think they're all on salary. Their panel size is small. I want to say they had like 300 or 400 people in there, maybe 300 people in their panel. And they've been rolling this out, and they actually will do home visits. That's where they care for people. And I think that as the patients that qualify for that are very much like they're seniors, but they're very much similar to what we're talking about here, which would have benefited you tremendously to be in that program. Exactly, your testimony to that. And I think that would be a model, it seems to me, in a big system, at least like mine. Yeah. I don't even know. I don't even know how many patients like this we take care of. I don't have a clue. And it's like, so that would be a model that would be very effective. That I think at least it is for our seniors, our senior population.
And I think we have to look again at what parents can do. I called the doctor and said,
it's well said.
And I said to them, we have other skills. We're not just parents.
Yeah, it's true.
I have 2 degrees, so I'm not
Absolutely.
stupid. Okay. And
Absolutely.
so I called the doctor and I said, if I call you at midnight with sick Maddie, what do you need me to tell you so you can act efficiently if you're sound asleep? And so he and I went back and forth on what we needed. On my front door, I have front and back everything that you need to know about my kiddo. My EMT office down at the end of the street that comes with the ambulance and the fire department has a copy of it. It's taped to my front door, trach size, how much is in the balloon, everything you would need. And we could help you do that. Residents, I think we should hire or have residents, pay residents to come in and do some of your work so you can do what you do best.
That's a good
You know,
idea.
whether it's taking notes while we're talking or go through those records and fill out a sheet like we did as parents. We taught parents how to use a one-pager so that when they came into you, they didn't waste your time. And they filled it out and they said, oh, this is great. And then the backside was what you told them to do so they could follow through. But let us help.
Yeah, would just say amen to that.
Yeah.
You know, and I think that when I'm thinking of one patient I took care of, very complex, I still take care of her. You know, when I started taking care of her, she was a transition case. She's very complex, and I mean, mom had a binder,
I do too.
and we sat down together with the binder, and you know, I knew what to do with that because of my training, but it just sort of that made all the difference. And when there was rocky times because she'd get admitted to the adult hospital for the same reason. It's like, well, her endocrinologist is a med peds endocrinologist, you know. So, but it worked. But it's like I think because mom knew everything.
Yeah, I have a treatment binder,
That's
so
right.
it tells you that.
Absolutely.
I have a MAR, and
Right, that's absolutely
all the 63 med passes that we had to do, it shows you each med,
Yeah,
where it goes, and what tube. Everything is there. So, and it's on a jump drive it was tied to her wheelchair. So if we got in an accident, it was there so that somebody could see it if something happened to me with a note, wheelchair bound dependent patient.
So it's
Plug in the jump drive.
sharing the teachings from parents
Yes.
to have things organized. And also, are there ways for us to create bundles of care? So we're paying both the pediatrician and the adult doc for taking them on.
Yeah.
And giving them a time period around which they can both bill.
Yep.
So
Right.
they're not
Yeah.
getting themselves into trouble.
I agree.
So I will interject that probably could even be 15 years ago now. I went to a lot of the various health plans with our chief medical officer in the state, in the metropolitan area, and said, you know, these patients are not our patients, meaning children's hospital patients. They're your patients. You're insuring them. And when they eventually, for lack of a better term, age out of our pediatric hospital, they're still going to be your patients. And so the issue kind of ownership of the patients comes up at times. Both who owns, in a sense, who owns the care for that patient, and also who owns, we could talk about ownership of the process of transition. But I'd be interested to know what any of you think about with the ownership of the process. I mean, CentraCare is a health system but not an insurer, correct?
Right.
Alina is a health system and hospitals, but not the insurance company. Health Partners, Park Nicollet, which you belong to, is both, as Medicaid system kind of is. It doesn't have the clinics, individual people, so it's more the insurance. Mayo is everything to everybody. So, you know, is it different depending on where you're at? And how does that play into this?
Well, I mean, it's an important question of ownership. And I think it reflects kind of that broader society question too, right? Of what do we as a society how do we agree to treat each other? And amount of supports we agree to give each other, you know, no matter one's underlying health conditions. And so, you know, fundamentally the state is where we've kind of said this is where we're going to hash that out. This is where we're going to have that conversation. I think there is a role for the state, this is where it gets a little tricky because some folks are going to be on Medicaid, but not everyone. And so then they're in the Department of Health technically. And so our Department of Health is DHS. Are we all talking about this group together and figuring out, you know, what that looks like, what our responsibilities are? You know, to kind of answer some of the previous questions about like, you know, payment and cost. If you were to come and talk to us at the Medicaid agency, you know, our reimbursement rates are set by the legislature, or even things like kind of trying to do innovative payment models, bundles. We are a lot of the times, you know, at the mercy of what the legislature determines that we can do and focus on. And so I think there has to be that lever of engagement, not only of parents educating providers, but parents educating the legislators so that they understand the impacts of these decisions, right? And how do we kind of, organize that? And I think some of the limitations too about so we have, ACOs or accountable care organization type models are integrative healthcare partnerships that look at population-based ways of reimbursement, giving a per member per month fee instead of just a fee for service model. And I think there are limitations to that too, particularly in this patient population because of the patient size. You don't have as many folks who have less complex needs, or really anyone by definition that has less complex needs. And so, finding cost savings is going to be hard to justify that type of model. And so again, it gets back to some of these bigger questions of who deserves health. Is it only the folks that can pay for it? And if we kind of still continue to operate under that system, we're going to keep running into these issues because you're going to have those as you said, reptilian parts of the brains of people flare up as far as like, how's this impacting my bottom line versus how is it impacting the care I can give? How is it impacting the care of my patients and the communities I work in?
So I'd like to say something. Everybody deserves good health care. Everybody. And it's the reason we all went to medical school, right? Because we believe that's the right thing to do, and we need to equitably give as much care to as many people as we can. These children that we're talking about, if they have private health insurance, they also have state health insurance. That very few of them have just one, and just the private. I mean, they almost all have both. And one of the largest challenges is that we have a different system for every state across the country. And things change from state to state. So I think the opportunities are endless. And I think if you think about, can we provide better care coordination, better handoffs? If we were able to prevent one hospitalization a year, one ICU stay every couple of years,
Absolutely.
it would be a tremendous savings for that individual and from a cost perspective. So I think the barriers are large, as you point out, and there has to be some sort of coordination. Maybe we need to work with our legislators more, to your point. But I think it needs to be elevated to a national level.
We've got about 5 minutes left before we take a break. Final thoughts that people would like to add for this section on things you've been hearing about, or there's been a couple people that have mentioned things that work really well. You mentioned that, first of all, as a pediatrician, geriatrician, you think that some things work better in geriatrics. You mentioned one program. Or maybe you've got other programs, especially for those of you who work in a system where you cover all ages. So at CentraCare, potentially that pediatrician can transition the patient within the same EMR to somebody, maybe even in the same office, who can provide that care. I know the Park Nicollet where you work has the same thing, and clearly at Mayo. Are there lessons that you've learned that you think could be emulated as we go forth with this? And take just a couple of minutes to finish up on that, we'll take a break.
I think and I think I made this comment before the audience was on, but one of the reasons that I came to Mayo was for that very reason, is that I could stay within one system for my survivors of childhood cancer, which has a lot of benefits. And I think going back to your connectedness point, I think when I think about successful transitions within the system, it's always been that relationship, that I've been successfully able to transition them because I told my patient it was going to be okay because Dr. XYZ could be trusted. We had a relationship, we had a conversation. And so thinking about that, I wonder how we can bundle things where joint appointments can be done in person and in telehealth and make a connection so that the family feels safe, so that the family knows that all the important things were delivered both in documents and in a conversation. And so can we figure out a way to do that? Because those are the places where I see it work the best. When it is a transition where it's sort of just Dr. XYZ because they're they happen to have a cancellation that day and I slid them in, those are always rocky. And so even in this world of kind of fast-paced technology and advancements, there's still something very sacred about that patient-physician relationship and physician-to-physician connectedness that our patients, I think, and you can speak also, that I think they really want and desire and they deserve. And so let's leverage our technology to make those connections and bundle it together in a way that's cost saving so that the handoffs aren't rocky. And how do we do that as a system and as a state? I think in a place where we have a lot of rural healthcare and a lot of outlying states, that state to state Medicaid gets tricky. When people maybe on a pediatric Medicaid plan and then turn 18, what happens to them and where can they go and what are the limitations? Those are some other issues in rural healthcare. If you're just south of the Iowa border, what happens to you? I think those are some big questions.
Others?
There's a great book written by two doctors that talks exactly to what you're talking about, the relationship. It's a podcast, but it's also a great book, and I keep bragging about it because I've read it and shared it with doctors. It's called Compassionomics, and it's got great studies in the back where these two guys said, compassion, empathy, do we need it? Well, how does that work and why? And what they proved after they decided to research it, and all these studies from all over the world, was that with the relationship, there were better health outcomes because there was a relationship. You wanted to make your doctor proud, so you're going to take your meds, or you're going to do this, you're going to do that. There was less doctor burnout. There was better relationships between patients and physicians. This book is outstanding, and it talks about that very thing, how we can get together and figure this out so it's a win-win for patient and physician.
And with that, I think we're going to call this part of our session to an end. I want to say thank you to all of our panelists so far, and you're not off the hook. You got another couple of hours going. We look forward to hearing from you more as the afternoon proceeds. We're now going to take a short break of about 10 minutes. And audience members, please think about questions you have for the panelists and feel free to send them in the chat part of your Teams meeting here, as we will be opening that function now. Please try to keep your questions brief. I see that there's currently 230 audience members. Even if only half of you submit a question, we're going to try and do our best to work through it. So take a break, stretch your legs. We'll get back to you in 10 minutes. Thank you.
Hello, and welcome back to part 2 of our transition roundtable, where we will expand on the topics discussed in part 1 by digging in a little deeper with questions from our audience. As you all can see in the chat, it is exploding and there are tons of questions, so we won't be able to get to all of them, but we will do our best to synthesize. If there are important questions, please use the like feature to really show emphasis on questions that we want to get addressed today. As for some ground rules for our panelists, our goal here is to learn from each other and hear from each of you how we can work across the silos of our systems to bridge the gap that is often present when we start thinking about big systemic barriers. So I will call on an initial panelist to answer the question, and then from there, other panelists are welcome to jump in, ask questions in response, and really make it a conversation. Don't feel obligated. Not everyone needs to answer every question. And I may have to cut off some of the conversation at some point to just kind of keep moving on to additional questions. So with no further ado, question number 1 is for Dr. Elting-Ballard. Should the process for transition be different for young adult without special needs, those with special healthcare needs, and those with complex special healthcare needs?
Well, I think it would be different, just because there's going to be for a traditional young adult that has no healthcare needs as a healthy person, that's not a very challenging situation. That person typically, I would say in my practice, goes away to college or university and then finds another doctor, gets a job, moves away, and it's done. And a lot of times there's not really anything to transition. That'd be my answer to that. I think as patients have more and more complexity, especially the ones we're talking about now, right? That is, in my mind, a lot different and requires a handoff, especially if you're talking about a trach, an event, and a G-tube, and a feeding schedule, and therapies, and multiple specialists, or, in the patient I'm thinking of in my mind I took care of had panhypopituitarism, and she had a whole bunch of problems. And I think that's a lot different than, a healthy young adult, I think.
One distinction I might add is we talk about medical complexity, which is what we're mostly focused on, but there's also the complexity of social disadvantage,
Absolutely.
right? And so we know that, for instance, children who are in the foster care system, need additional, so they might medically be fine, but certainly could require more intentional connections to resources and supports. We know that kids on Medicaid's parents are less likely to have employer-sponsored insurance, and so they're not going to be necessarily covered under their parents' insurance up until age 26. So how do we kind of connect them to make sure that they continue to stay enrolled when eligible? So I do think that there's opportunities to think of both the kind of medical complexity, but also, how does social disadvantage, even for some of our medically complex, they're also dealing with those social disadvantages, and so making sure our systems are kind of having that as part of the steps we take to help families and children transition.
That's well said.
And Dr. Tilstra, from your experience in rural healthcare, can you talk about the value of community health workers and where they come in this world of transition?
Incredibly important. I didn't talk about them earlier, but our system uses community health workers in a couple of different ways, and in the larger population centers, I'd say, they're usually working with more of an ethnic group than they are necessarily with a special needs population, but they can be invaluable in helping to transfer information, to help the patient understand what's going on, be that patient advocate, help the patient, understand the point of view of what's going on from the clinician side, and then help the clinician understand the point of view of the patient. And so it's a valuable role, a little different than a care coordinator, but absolutely can be part of the solution.
And Pat, have you used community healthcare workers in your own experience?
No, but I have taught community healthcare workers. I just recently did all of the healthcare workers in the state that signed up for a class, the licensed, just to give them a parent's perspective. I didn't have, any need actually, but they were amazing and had great questions, great work ethic, and were supportive of the needs of parents, listening and trying to figure it out.
And are the community healthcare workers typically from like county level, or are they from your system?
In CentraCare, the CentraCare hires them.
Okay. And would UHG ever think about having their own community healthcare workers?
In all transparency, I bet they do, but I don't know.
Mm-hmm.
We have so many different systems. I would be surprised if there are none.
Mm-hmm.
I just don't, I'm naive to that, I apologize.
Yeah. And are there community workers through Medicaid?
So Medicaid does reimburse for community health workers. It's quite low, though. It's not really sustainable to, if your population is only Medicaid patients. And so that's kind of just an underlying issue that we've heard about. And then I've also heard from other systems who do use community health workers that often one of the limitations can be, since reimbursement is either not existent, so not all states reimburse community health workers, not all payers do, but is either non-existent or very low, that they're really kind of restricted to work for specific grants. And so they bring a community health worker to help it with diabetes management, or they bring a community health worker to help with stroke, post-stroke care. And so that is a limitation that we see, is that just having a community health worker that can kind of be helpful for everything is needed, but the reimbursement side is still not yet figured out.
Mm-hmm. Mm-hmm. Absolutely. And this is for Dr. Chomilo again. Is it possible to hardwire the provider handoff into the Medicaid or Title V quality metrics?
It's a good question. I mean, I think quality metrics are a lever, like I talked about at the beginning, that we can use to try to push providers or the payers that we contract with to prioritize some of these issues. I think the kind of number of steps, that are needed in a successful handoff would make it, I think, a little difficult to make it sure every piece is hardwired. You'd also need a benchmark, right? And so we talked about the lack of kind of valid measures that we know lead to the outcomes that we want, right? And I think that is a challenge with quality as the way to move things, just because it can be very possible that your quality metrics move up, but you haven't really done anything to change the care. You've just changed how you effectively reported it and captured that data, right? And so I think any quality metric that was hardwired that to be successful would be to kind of Pat's, kind of reminding us we need to listen to what works in the from the parents and providers and the caregivers and really build it up from there. I don't know of any existing measures that could work, but it's a possibility, yeah.
And do any of your systems currently have measures of transition success or other measures that are surrogates that we're using?
Resounding silence.
Yeah.
It's a great question.
Yeah, I think the answer is yes, but not about this. I mean, I think it's more of like inpatient to outpatient kind of stuff, which may not be relevant.
Yeah, transitional care management, not
Right.
transition from pediatric to adult.
Right.
That makes sense.
There's some new efforts ongoing within the Children's Center at Mayo Clinic, which I believe are largely related to the gottransition.org. But in the Cancer Center, we have not been part of that effort yet on deck. So I don't have all the information on that, but I think it is ongoing.
And Pat, what measures would be important for families?
I think families need to know that as they prepare for that transition, who is going to take them, what their success, not success rate with the disease specific, but what it's going to be like. So it's a gentle transition, if you will. What it's going to be like in the hospital setting, not just in the clinic. So how many doctors are there to choose from, whether they're in the cities or in their rural areas? How many and who are they that we can choose from? The other subsets are the physical therapy, respiratory therapy, all the different things that they would need to give them numbers of here's how many we have and here's what you can choose from, so you know what you can do, and these people are qualified and willing to take you as a patient.
So we do have something that I haven't talked much about. It's called the Special Needs Initiative, which is a system within the employment and individual side in UnitedHealth Group, where we support families who have children with complex medical issues, and we support them for insurance resolution issues, and also have some efforts to try and support them medically, partner with health systems. And there are a few health systems that we are partnering with. I would call it on a semi-pilot basis. We have 4 or 5 hospitals right now where they have children with complex care, and one of their measures is transition to adulthood. So it's one thing we're looking at partnering with them about.
And we've talked a lot about how care coordinators are important in this transition to adulthood. So Dr. Wendy Rhodes, how can a care coordinator really assist a family in facilitating this transition? What is their role in this?
I think we were just talking in the break about how care coordinators are utilized differently in each health system and each division within the health system. And I think when I think about transitioning my patients, and what I'm hearing from Pat, is that care coordinator could act as a bridge. And so when the transition starts, if a touchback needs to happen with the previous provider, that care coordinator, in my opinion, could be the person to bring it back to the original kind of sender of care, because nobody wants to have, all right, on June 13th, you were transitioned, and then forevermore, you're in the adult system, and no questions can be asked back. And so having that person work as a liaison and a touchback to the sender, I think would be exceptionally important, and helping the families make sure that the information that is high yield and needed to the receiver is there. Sometimes as providers, we don't always think about the nuts and bolts of what is needed on either end. And so somebody that can bridge that, I think, is going to be the most beneficial and the most useful. But I don't ever want to, 10 years from now, that transition should be complete. But 10 days or 5 weeks from now, it might not be. And so how do we bridge that and have a touchback with our sender?
Yeah. Wendy Burkhorst and I did a transition call this week and asked for feedback from families from all over. And one of the persons that came on was a care coordinator in Florida. And I may be wrong, Wendy, but I thought she said she had 50 physicians in several different clinics, and that was her role. And her role was to bridge the gap between physician and patient and families, and help them work through the system. I am going to have a meeting with her this week, I hope, to talk about exactly what her role was, but she was on our call to hear what patients had to say. So she was there to learn and listen, which I thought was awesome, to see what families were saying about what needs they had. So I think that goes to how great this position could be.
The other thing that I would add is, remember, parents end up being the coordinator of the coordinators.
Oh, yeah.
So every health system has a different coordinator.
Yeah.
So, I mean, if we can find a way to relieve that from the parents and have the coordinators actually work together,
Amen.
that'd be great.
Yeah, amen.
And there are some health insurance companies that have care coordinators as well. And I'm not sure if it's UHG that has that care coordination role as well. But have any of you worked with the health insurance care coordinators for assistance who might be able to be that care coordinator of care coordinators? No.
And, I mean, in our system in general, we don't want to do the work for the health system because it tends to get in the way. What we'd rather do is support the health system. So try and find ways to support the local coordinator or help them with the insurance issue resolution for those children or adults.
Yeah, in my clinic side, I have a care coordinator in the clinic, and so that's who, if there are other care coordinators, whether it be from health plans or sometimes folks have a county care coordinator or worker, they're usually the ones who are kind of helping navigate there. But that's an interesting question. It's an interesting response too from the kind of Medicaid side, because I was looking in preparation for this roundtable, like what other states are doing in this area. And so I found that in Texas and Pennsylvania, they actually have in their managed care organization contracts. And I guess for kind of just a quick primer, Medicaid, the state program that's federally and state funded, then contracts with health plans like UnitedHealth Group, like Health Partners, Hennepin Health, Blue Cross Blue Shield, you name it, to take care of our patients, to basically do the care management or care coordination. And so that's one of the levers as a state we have, is by putting it in, and 80% of Minnesotans on Medicaid are covered by managed care organizations in Minnesota. And so we put in the contracts, this is something that you need to do to continue to get your per member per month benefit. And so what they've done in Texas and Pennsylvania is actually put in their contracts that it's one of the deliverables is is to hire and train transition specialists that really are actively identifying members who need to go through transitions, actively supporting their transition from pediatric to adult care. And that's something that I haven't seen in our contracts yet, or even in like the request for proposals that we put out that healthcare organization or managed care organizations have to fulfill. And so I think that is something, here in Minnesota, but also to kind of our discussion, nationally, what's a kind of a national benchmark we can look at and say that is your state doing this, then your state could be doing more to support children with these complex needs.
And Dr. Elting-Ballard, when you think about your own private primary care practice, when you think about kind of this coordination of a patient like Maddie Lang, who had 16, 20 different specialists, how do you even begin to navigate that?
Well, it's very challenging. I think probably that, at least when I've done that, it's me doing it, right? It's me doing most of that work, I think. And oftentimes working with mom, it's usually mom and dad, usually mom, and that magic binder. It's just very challenging. I think I don't even know what else to say. I mean, I'm just having a little PTSD just thinking about it, sitting here. Truly, it works out. It has for me. I don't know that there's any one way to do that. It just requires me to listen to what the parents are saying. I have a high trust for them. They know their kid, and oftentimes in some of the circumstances, just because of my background and because I trained at the university, I know the doctors who are taking care of them, which has helped. That may not always be the case, so I know their specialists, and oftentimes I was their resident or so I mean they had a personal relationship with me as well, and so that really helped, and it facilitated sort of the care. If I needed something, I could call them, or if I had a question, I could call them, which is what I would do. And but there wasn't anybody else. There's no other person to help with that. No. I mean, it was thee and me, and yeah, right. It was thee and me, and it just sort of that's what would happen. And it gets tricky when that person. I'm thinking of a patient now. Gets admitted to the hospital. And has all these medical problems, and oh, by the way, we found a new one. Then this person, it was familial polyposis, and she needed her total colectomy, and at an adult hospital by an adult colorectal surgeon, being managed by adult specialists who had never seen this person before, and it went well because the endocrinologist was part of this. Who I'm thinking of knew me and actually knew her endocrinologist. Wow. And so, because it's a smaller community, they didn't work very far. So that helped, but that was a challenging time. And coming out of that, and then follow-up, and where do we go for follow-up, and how do we do that? And because that patients continue to need ongoing follow-up for a lot of things. So I think it is a high-touch kind of experience. But it went okay. I think it's a lot of it. Again, it's the physician and me doing it, and mom doing it, and the people I trust, and they trust me. And it would have been great to have a person sort of there to help with all that, but that doesn't happen usually. Yeah. I don't know if I answered the question. I kind of maybe I did.
No, I mean, I struggle with this in my own practice for sure. When you have this list, right? 20 providers in the course of the next 3 years, we need to change all of them.
Yeah.
Right? It happens. This is day to day, every week. I see multiple patients like this in my clinic office. So I'm wondering, Dr. Mendelsohn, what is the role of the insurance company? Because there are so many restrictions that the insurance company puts on the ability for this to happen. We might have a really well thought out plan and then we find out, oh, this isn't covered.
Well, it's a good reason to involve the insurance company sooner rather than later.
Amen to that.
You know, to try and have us help people better understand their plan and what is covered under their plan.
Amen.
Right?
Yeah.
And almost always, we can help people know which clinicians, you know, are in their networks.
Mm-hmm.
And if they're not, and there's a very good medical reason for that, then we can explore that and help understand better what the options are. But I don't think the goal is to put restrictions. I think the goal is to find quality care and make sure people are partnering.
So is this a situation where in the exam room, the visit could be, let's call your insurance company together and use this time together to figure out how we can do this?
Oh, it's a great question. I mean, the operationalizing that is going to be different for every health system and for the families. I don't think doing it in the exams room is the best use of time for anybody.
Mm-hmm.
But encouraging families to make sure that, you know, I'm gonna refer you to see Dr. Smith at this healthcare system. I'd like you to call and make sure that he's within your network, that you can actually see him. And if you can't, let's talk about why I want you to see him and what is special about this doctor that he's the only one you can see. And if not, then ask them who else has these kinds of qualifications that you can see and come back to me with it. That's why we start when the kids are 14, right? This is not a one and done. It's a long process.
Mm-hmm.
Can I say something just in comment on that? You know, in a past life, I was a medical director at a health plan in town, and I did complex pediatric care. And one of the things that I talked about there, and I haven't seen it come to fruition, and I'm just a part-time guy, is there's really this triangle that I saw between patient, health plan, and provider. And, you know, we sometimes have this adversarial sort of relationship in that triangle, and it's messed up. I don't know how else to say that.
No, it has to be a partnership.
It is a partnership, and it's like, I would say, you know, your health plan is out, you know, they're out for your good. I'm out for your good, you know, and I think there's so many things that as a physician I learned doing that work that, you know, that's not something you learn anywhere else. I never would have learned it. And I think physicians need to understand things about health plans that I don't think we understand. Patients need to understand things about health plans that they don't understand. And I think there's just there's an opportunity for a collaborative experience there that maybe that's happening better now. My experience on my end of that is it isn't. But it's just, I think there's an opportunity to eliminate that adversarial sort of nature.
I think we have a culture of, let's just do this off the side of our desk, right?
Yeah.
Mm-hmm.
And we can't do this off the side of our desk.
That's right.
Yeah.
These are, if you think about it, these children and young adults who are transitioning are very sick. They are our best clients. They're our best customers because they come see us the most. You know, and so we need to have resources to help them, and we need to take time to help them.
Yeah. And I also think that, you know, the insurance company, be it that they don't always understand what the families are going through. It's like, this is how I'm taught to handle this problem, and this is what I'm going to do. I'm not going to think out of the box because I don't know what this is like. To your point earlier about legislators, and I also did insurance companies, I invited them to my house. And I had a couple county commissioners, I had a congressman, I had a Republican and a Democrat, and I had prices, and I had a couple people from the insurance company. They were actually my friends that used to work with me. I had prices on things so that they could see what this is really like. The Carver County Commissioner went out front and was like, this is like a PICU. And I go, an expensive PICU, if you will. I said, look at all of this. And he was like blown away. And so even my friends that worked for an insurance company, then they went back to that insurance company and said, do you realize she's saving money here and here and here? She's not trying to take the system for anything. She's trying to keep her kid alive. Yeah, and I think people just need to, wake up. I stood up in a town hall meeting, which wouldn't shock Sheldon
Yeah.
or Wendy, to get their attention, to say, listen and come.
I think one of the great things that we've learned in the last couple years is that people with rare disorders are the 1%, and the cost is disproportionately high, right?
Absolutely.
And in general, the way you and I and most people think about the insurance companies is that they say no, no, no,
Yeah.
no. Well, those systems were built for the 95%.
Yeah.
And so what we are doing now, and the reason I'm at UnitedHealth Group,
That's right.
is to build a system for that 1 to 3%.
That's right. That's right.
And so the advisors in our special needs initiative, they don't get the usual 2-week or 3-week training. They get 6 weeks training, and they are preferentially hired for people that have experience of individuals with special health care needs.
That's awesome.
So we have to all start to look at this elephant with that lens.
That's awesome.
And what can the AAP, big commercial payers like Blue Cross Blue Shield, state Medicaid agencies do to request and establish a standard practice of bundled payments for both pediatric adult providers during a pediatric and adult providers during a transition? So doing the idea of having the virtual and live patient or live providers in real time seeing that patient together. How would that even happen?
So ask it again. I'm not sure I totally get the question.
So how do we go about making that reimbursable for all of these people to come together to have this conversation, to care for this patient in this innovative way? Where does that start? At the legislature? Is it lobbying insurance companies? Grants?
Yes.
Well, I mean, I think you have to kind of determine what you want included in that, right? I think that's where then you think the professional societies, so the American Academy of Pediatrics would have a role in saying this is what a standard of care, a national benchmark looks like. If you look at things like what's covered in our EPSDT benefit, that's really guided by Bright Futures guidelines, which come out of the American Academy of Pediatrics. And so I think there's a role there for our professional societies to kind of lead and say this is what's needed. And then, yeah, we'll take, innovation on either the federal side or state sides who can do, waivers to do special packages. If you think about like the healthcare home, came out of that process of like, let's try and find different ways to bundle different services, pay at different rates, and see if we get different outcomes. And so there'll probably need to be some states or some areas that are able to do that. Some payers could always do that. Payers can do so much. They've got lots of money and resources, so they've got to kind of make the decision and make the numbers work for them. But I think that would be the kind of path, would be starting with what's the standard from the professional societies, and then who's willing to step up and try it, measure it, and then from there hopefully we can get it taken up around the country.
Mm-hmm. And then Dr. Tilstra, how can we use social workers better in this transition?
Social workers, I mean, they could be the equivalent of a care coordinator in some instances. I'm not sure exactly how the question is looking at the social worker as opposed to some of the other roles that we're talking about. But I would expect that some of our care coordinators probably are social workers. And if they don't have the degree, they probably should. There's certainly a part of, trying to figure out what are those systems that are available out there, what are the needs that these families have, and trying to connect things together. So I think they're part of the equation. And, getting to one of the other points that was made, I think one of the things we've got to do is really define what does a successful transition look like? What is that standard? And, from there you can start to plug in these people and say, okay, this is how this all needs to work. And from there you start with an insurer who says, we'll experiment with this. So I think it's all part of a big equation that it's a big elephant that we have to try to figure out.
One additional kind of lever that we haven't talked about is kind of community benefit, right? A lot of our large healthcare systems are supposedly nonprofit, and so to get that status, they are supposed to be investing some of the funds that they don't make back into the communities, right? And so what are they doing with that, and how are they demonstrating that, and how could this potentially be an area where things like social workers, like care coordinators or transition specialists are supported through that community benefit lever.
And I think,
the other thing I was going to add to the social worker piece plays off of what Pat said. I think there's a role for our social workers and other psychosocial support services to support the family through the transition. It can be quite traumatic. And so how do we as a system define that? How do we provide that and potentially provide reimbursable services? It depends on the state you're in, whether social workers can bill or not. But I think a successful transition has to support the caregiver through it. And I think that's a role for the social worker that falls far outside of the purview of my training as a physician. And we rely heavily on that in my day-to-day practice. So I would put a little plug in there for that.
That's good. That's good.
absolutely. I think one of the things that's hard about transition work and really kind of wrapping your head around what it is that we often think about it as just one moment in time, when really we're talking about like a decade of our patients' lives.
Yeah.
Right? It starts when they're 14, it ends, maybe when they're 30, maybe 2 decades. And it's hard to wrap your head around what success is when you're talking about this, or what are the measures through which we can say that, okay, we're making some progress. So does anyone in their own clinic or their own experiences have definitions with which they're using for what success when it comes to transition is?
I wouldn't say I have measures. One of the challenges is setting up the project to look at the final result when the two healthcare systems are separate. So if you're going to do a quality improvement project or a sprint or something, you then assess the outcome on the back end with the stakeholders. So how have we done or not done that in our respective systems? Even in a system that lives all under the same roof, it can be challenging to get the feedback and the information that we need from the providers. Parents are always willing to provide it, I will say. But we need to be more systematic about it, because even if we have a measure defined, if we don't get the responses from it, it's worthless.
Mm-hmm.
Mm-hmm.
So I'm going to channel my inner Tom Kelly, who was supposed to be here today. And what he would have said was, success is when it's as easy for the complex child as it is for a typical child, right? Like, it should be just like our typical children who call up, get their appointment, go see somebody, interview them, see if they like them, and continue with them.
Yep.
And I'll say, I think you're touching on a real important point there, in that the levers we were talking about of how to change the system, that's hard for them to kind of realize their own benefit over the course of a decade or more, let alone like 2 or 3 years or more, right? If you think about even talking to legislators who have to show results every 2 years, or a state agency that has biennium budgets and having to show results and cost savings in like a 2-year period, and I can't say that if we do this now and spend this money now, and it's going to save the system in 10 years, I can't capture that in any proposals that we're putting forth as an agency. And then insurers who might be covering them when they're at one point in life, but then a different insurer covers them when they get into the adult age. And so then they're not realizing that savings directly either. And so I think we'll have to be really innovative, again, in how we think about how we're supporting this work, given it's over that longer time period than some of the levers really allow us to capitalize on.
Mm-hmm. And Pat, is there threads amongst families of what a successful transition looks like?
I think it's ease of finding the doctors that you need to get the same kind of care, or try to get equal care that you got in the pediatric system. A lot of people aren't as forceful as I am, as Sheldon knows. And so there are a lot of people that don't know how to do that. We help them do that through PACER. So I think trying to get that so they can sit back and go, oh, I got 2 doctors now that my child can see. And I know where they are and I can feel safe. Whether my child can talk or if it's medical complexity, and you feel safe when you go to that doctor knowing that they're going to do their very best. And if they don't know, that they're going to call your pediatric provider or somebody to get the help you need so that they feel safe. That's the success, is feeling safe and taking some of the load off of parents. We're taught to do everything, plus our job. So.
Yeah, I would agree from my own practice. Certainly when I feel successful is when a patient comes back and says, I went and saw that primary care you suggested, and they're it. They're the person for me. Awesome. So we've talked a little bit about Pat's experience at the ER and being told on both situations, both sides of the river, that it wasn't the right place for her. So for those of you in adult systems, are there things happening at the ER or inpatient level to make care more equitable and care more better for our transitioning patients with medical complexity?
You really want to hear my opinion? I say no.
I don't think so.
I say no.
So I do have a small group of med peds hospitalists that I get together with. We've met a few times to talk about how do we do this work better from an inpatient perspective. And we're fortunate in the Twin Cities, at least for Alina and Health Partners and the university, to all have med peds hospitalists that work in both the pediatric and adult spaces. So the knowledge is there, and I think it's just igniting the system around them. And we're starting to have those conversations about what's happening at your system that we can kind of piggyback into our system, or why didn't that work for you, and really learn from each other. Because what I do know about transition and medically complex patients is they don't just go to one system. I don't think I've met one patient that gets all of their care in one system and there is no communication that needs to happen outside. So the collaboration is really, really important and crucial for success. This is a question for you, Pat. How, as specialty healthcare or complex healthcare providers, can we empower and allow these patients to advocate for themselves to the best of their abilities?
We try to teach advocacy skills not only to patients, to the kids that can do it, as well as the parents. So we teach them how to do it, how to ask the questions, how to do it constructively and not critically. So we work. And that's one of the things that we're aware of. There are some kids, like my daughter, who could not speak. Did she know? Yes. And if you talk to her about certain things, she would close her eyes. She knew. She was totally aware, but she couldn't talk. And so there are kids of all different levels, and you just have to decide, can they, can't they? but we try to teach, and hospitals and clinics could do the same thing. Let's have a clinic on Saturday that we work with kids that are about ready to go that can speak up for themselves. You know, one of my friends is physically disabled. She's intelligent. She just graduated with a 4.0. She can talk for herself, but she can't drive herself to appointments. She can't do this. She can't go get her meds. So there's different levels that we need to think about and then teach the advocacy from that point.
And there's several comments about other ancillary folks involved with healthcare and what is their role. So one question that came through was, how can other health professionals like pharmacists assist with transition? Any thoughts?
It'd be great. I mean, I think there's a very strong role for pharmacists, right?
Yeah.
Yeah, I think pharmacists is one piece of it, social workers, which we've already talked about. I can imagine scenarios where things are compounded and formulated to go through G-tubes, GJs. I read that in the article that you guys wrote together. It's probably not commonplace in adult medicine where people are able and willing to swallow tablets and things like that. Yeah. And so I think all of these transitioning adults are going to continue to need the team, right? It's always a team. Yeah. And finding that person to accept that team and transition them as a package, a payer package, a team package, a support package is the only way that it's going to be successful.
Yeah. Mm-hmm.
Team is the key word.
Yeah.
Right. And our pharmacists are so exceptional. When they get a prescription from an adult provider that says crush a pill, they're like, what? She has a GJ tube. She doesn't do anything by mouth. And so I don't even know that they did that, or they don't say G or J tube until the pharmacy calls me and goes, hey, Pat, I fixed it for you. And what he did is he called the provider and said, where do you want this? We need to put it on the label, J or G. And we can make a suspension that will be better. Omeprazole, Baclofen, whatever. We can make that and not do a pill that's going to jam up a tube and cost them $7,000 to change the tube. And so they're on our team. They are amazing.
Yeah, and I would just add having them maybe even earlier so they can even look at what are your different insurance options and give you a real estimates of what it's going to cost when you do make that transition going with A, B, or C would be really helpful as well.
Yeah, I actually, right before this, I was, a family was wondering about transition and medications and everything. And I'm tasking the family with their pharmacist of, what are all your meds and who's the prescribing doctor? And then how do we build a system around when we transfer over your pulmonology care that those prescriptions get switched over to? Because it becomes very difficult for families because they're just going with the flow, keeping their child alive to figure out actually the pediatric pulmonologist has still been filling this for the last 3 years. It's just kind of been happening behind the scenes until a new pharmacist comes on and they notice that, well, why is this person prescribing? So, there's a lot of systematic things I think that we can do to make the little things that become very troublesome for families and also cause providers a lot of distress because all of this paperwork starts coming at them of, well, I don't know what I'm supposed to do with this.
Yeah.
So, and then as a school nurse working with both medically complex and students 18 to 21, how can we get more involved in transition?
They just have to understand what it is, what the system is like. I know in Maddie's case, we had the home care nurse. And so I said, why don't you talk to the school nurse and teach her what you do? So she understands the role that you play in our home, because I think in the beginning it was kind of a threatening thing because she was going to school. And in Minnesota, not all districts allow the home care nurse to go to the school, which is a fight that I have to fight for families. But once they talked to each other and they realized what this nurse is doing and understood that, better, then I think it was a good relationship. And we even invited the school nurse to our house and said, come see what it's like. We actually did IEP meetings, I probably shouldn't say this out loud, but in our home, so that the people writing the IEP for her or the 504 could see what it was like and understand. So they did this and created it with her in mind.
That's great.
Yeah.
Yeah, and I'd say helping families know what maybe are services they're getting at school that are covered through like educational funded services, or those Medicaid funded services that are at school that aren't covered by most adult insurances, so they can start to understand and plan how are we going to fill these gaps, who do we need to talk about. Certainly the school nurses can play a real important role in helping parents just know exactly how these services are funded or covered, and help plan for that part of the transition too.
I don't see why a school nurse in our virtual world and my telehealth model shouldn't be invited to transition planning meetings. I mean, there shouldn't be a scenario where that couldn't happen,
That's good.
either visually or audio wise.
That's a good point.
Absolutely. Yeah, I think one of the great things to come out of the pandemic has been just the opportunities to be creative about communication and telemedicine and collaborating. I mean, in my own practice, one of the coolest things is when I have a patient come from a group home, patients in my office, mom and dad guardians are tuning in from home, and the nurse who is at the group home taking care of the rest of the patients can also log in, and we're all doing it together and thinking creatively about how do we get the care this patient needs. Otherwise, they show up with someone who cares for them once a month. And you can't make any decisions in that realm. So I think we have a great opportunity to really use COVID for good as it relates to this piece of care. We've talked a lot about communication. So has anyone had success in leveraging the EMR to develop a means to effectively transfer information to other providers?
No.
I'll say in our system, when Healthcare Home really initiated, we had gone through a fairly extensive process to build what was called the Healthcare Home report. Unfortunately, it no longer exists, but I found it as, the geneticist who was going to see a patient was often the home healthcare, that report was often the place that I could get the information the quickest. And so I found it an incredibly valuable tool. Unfortunately, not too many others did, and so it went by the wayside. But it's certainly something that could be done. I think it proved that it can be done.
I know of at least one company that can collate records from multiple health systems, and then the parents own the access, as do the multiple health systems. So there are solutions beginning to be built out there. It's not always perfect in the formatting, but it's better than most.
Yeah, we've tried, my previous institution, we built some things into Epic that was frameworked off of gottransition.org. We tried to adapt that to cancer survivorship, and it was not a success. And now there are systems that live outside of the EMR that are trying to glean high yield information to communicate back to PCPs. The problem therein lies that it might be good from me as the med peds or the oncologist talking to the PCP, but where do all the subspecialists live in there? And that's where I'm seeing the holes and the gaps, because you all have to put into it to get the output that you want in, garbage in, garbage out, right? And so if we're missing pieces of it, then it's garbage. And so those subspecialists that are playing into the care plan or the transition, that's where I struggle.
Absolutely. Well, we had so many questions. I think we maybe hit a tip of the iceberg in terms of all of the questions that came through. We will collate those questions and make them available so that when we put out the recording of this event. You also can see them there. We're going to take a quick break, and when we come back, our panelists are going to reflect on what they've learned today and talk about where they would go from here based on their perspective and representative roles. Thank you. Hello, and welcome back to our third and final session of the day. Our panelists have had the very easy task of reflecting on what we've all talked about today to really think about how we can translate today's conversation into action. So we will be going around the room, starting on the end of the table and rotating around to just talk about what you've learned. How do you put all the pieces together to move forward from today? So, Dr. Telstra.
You ask such simple questions. What I've learned, there's a lot of thought going on about transitions of care across Minnesota as well as across the country, it sounds like. And, there are pieces out there, at least pieces of the puzzle are probably being worked on. No one has it pulled together yet. And that we've got a lot of work to do to even figure out what this really means. What does transitions mean?
These masks make me crazy. I would just say that I'm energized by this. I'm energized by all of you, by Sheldon and Tori and Wendy and everybody. Joshua, you know how I feel. That you guys put this together in the first place, but then to sit here with you and hear the stuff that you say, things that families and myself included feel, and know that you get it. And now the thing I say is, let's do something. Let's don't sit around and do nothing. Let's take all that we got from here, the questions, the answers. Let's start something and get going with it, because you guys get it. I love it. I just keep getting chills because of the things that you say and know that you understand. So let's do something.
I'm very humbled to be here today. I sort of almost feel like an interloper, but I'm really happy to be here. And I think if there's one thing I've learned of being a pediatric oncologist is never underestimate the power of advocacy. In the larger world in which I live outside of transition, we've seen the power of what our parent groups and our advocacy groups and our physician groups can do to get payers, organizations, legislators to pay attention to us. And I think this is just another one of those issues that you just got to speak up about. And I think with where technology is, the opportunities lie. Payer organizations are listening. They're working on their own initiatives. It's time to, like Pat said, bring it all together and get moving on it. And I think that now is the time. And I really appreciate your comments about it's not just trachs and G-tubes. There's so much more to complex care for children in foster care system and English as a second language and all of those social determinants of health that go into it. And we have an opportunity here in Minnesota to be the best and be the leader, and I think we should do it.
Well, I couldn't agree with you more, so thank you. And I too am humbled to be here. I'm full of gratitude for the day. I think the system it feels still too complex. It all feels, I'll admit it, it feels a little overwhelming to me. And I think for me, I've always believed if we reduce morbidity and mortality and we will end up making the system of healthcare better for people, and then we will save money. And transitions of healthcare will reduce morbidity and mortality. It's the right thing to do to go towards the quadruple aim. So we have to do it, and we have to partner to do it.
Yeah, thanks again for having me, and really happy to be part of this conversation. I've learned a lot that I'm excited to also take back and make some connections. I think that what I really appreciated was the kind of what's our goal, right? Is that transition for a medically complex child is the same as a medically straightforward child. right? And so then from that goal, we can kind of think back and what are our, again, levers to actually move forward. And for me, that's, I think through a way of how in the bigger, system that I'm a part of, how can we make the right decision the easy decision? And I think we've heard that so many of like the complexities that you bring up are because we've put all these different barriers and hurdles to what is the right decision and what will actually have the needs of our families met and make providers get the care that they want to give, right? And so thinking of through what we can do to help, educate providers and have that be part of, engagement in the Medicaid program, thinking about what our state's doing to try to build some of these interventions into their contracts and to kind of hold payers and others accountable. And then how can we continue to develop what are the standards so that we find those measures that are community informed and led, and that we then embed that into accountability. And I think there's lots of opportunity to kind of engage our professional academies, continue to engage our providers, obviously our patients and families, and really kind of, again, make that right decision the easy decision.
Well, thanks again. I feel like humbled to be here and sort of not an expert in any of these things. I think my initial thoughts are this is very complex, and I can't, it's certainly bigger than I am. My initial sense that connectedness is important has been reinforced, and we seem to have a number of people, at least at this table, that I didn't know before, and that's helpful. I think these are important patients, and my sense is that when there's a crisis, like we just went through with a viral pandemic, we built a clinic in Uptown. It's a wonderful clinic. I'll advertise, and it really is wonderful physicians. And the aim of that site was to be sort of a model clinic or an experimental site. And one of the things we wanted to experiment with was virtual care. So we said, well, let's see how we can integrate virtual care into this work. And we started doing that 6 months before the pandemic.
Nice.
So, and that was slow to take off, right? And there was a lot of barriers to that. And all of a sudden, that's not a barrier there anymore. And we got to think of something else to do, okay? Because we all of a sudden are doing that. And I think if there's a crisis that says we can overcome some of the barriers of connectiveness and sharing information, some of these things are just really, I think it's possible to do. I don't know how to do that, but I think it's possible to do that. For my own self, I think I had a conversation with some of our care integration folks in Alina that we met with a pediatric group right before the pandemic. I'm going to keep them anonymous. And they said, we would love to transfer. We have all these kids we're taking care of in their 20s. We got to get rid of them. We don't know what to do. And, it's like, I said, well, I would love to take them. Not me personally, but I have clinics in the West Metro that I think could do this work. So my and that then the world went crazy, and that went on the wayside. But I think it's time to talk to them again. So that's just a small thing, as I sit here to say, I'm going to go talk to them again, and I'll reach out to our care coordination folks and say, what happened to that? Let's resurrect that, because there's children out there that probably now even more than 2 or 3 years ago need our care, and they're not in our system. They're not related to us, and you know what? That just needs to be okay, because they don't have the resources and we do, and we can help them. So I think that's a small thing I can do, and sort of to take action on some of this in my little corner of the world, and then continue to advocate for these patients in our system.
Are there other little action items that people have on their checklists on the side of their pages?
Can I push it and ask Pat that you were real clear, a lot of great stuff discussed, and now we got to do something with it.
Yeah. Hire me and I'll do it.
So what's your top 1 or 2 that we need to do next?
Oh, that's so good.
I would say that when it comes time, if you'd establish this is the age we're going to start talking for medically complex, let's say that's what it is, then everybody should know that. The hospitals should know it, the clinics should know it, the families should know it, And then what are the steps we're going to do to make all of those people, to educate, if you will, all of those people so that everybody's ready for it, so that somebody else doesn't pull into a hospital and they say, no, you should be on the West Bank. No, we can't take you. That should not happen here. I moved here for the U of M because of the excellent care we got in bone marrow transplant. I went home and left my whole family and could not fly back to see my mom pass away because I couldn't travel with my daughter. I believe in you guys. I believed in the system here, but it's failed. In her 25 years, it was the scariest time I've ever had trying to be in an adult hospital where there wasn't listening going on. There wasn't all the things that I have told you that we have that were instruments they could have used. I wasn't getting that. I wasn't getting the help that she needed. We got to fix that.
Amen.
So getting parents ready, utilizing the skill sets that parents have, partnering, like you said, with UnitedHealth Group or the insurance company, with the doctors, get a team together and let's go and do something. Let's talk to the people that have done it successfully. Wendy and I know, teams of people. The GOT transition people are amazing. I had Dr. Patience White. I met her, I just walked up to her and met her in Washington. And she's been like my friend for 2 years. She did a presentation for my board at Pacer and talked about transition. So let's get her to introduce us to people that have done this successfully, and let's go. Let's do it. Let's figure out how we can do it and get doctors paid what they need to be paid, get parents feeling comfortable with it so that kids can thrive. You're doing all these wonderful things. I told Jacob Toller at the U, you're doing all these wonderful things with bone marrow transplant, and our kids are living longer. Then what? Do we just forget about them?
That's right.
No,
Yeah, that's right.
we got to fix this.
That's right. Do you think that as one small piece of that, and what made me think of this is what you initially said is like nobody knew what was going on, and start planning for a transition at 14. So like my mind goes to my geriatric patients. We're working on this initiative, having serious illness conversations with people in Allied Health to develop, the aim is to keep people out of the hospital, and there's a multitude of aims. And one of those is the end result as a pulse, the physician order for life-sustaining treatment. Would something like that, or an equivalent to that, be helpful for someone like you to reach the age 14? It's like we need to have a transition conversation. I don't know if anybody's invented this. I'm making it up right now. We need to have a transition conversation, and part of that is some kind of pulse-like document. I don't know what that would look like. To say, here's what's going to happen, and then it goes on their chart. And it's a big banner on our EMR that wherever they land, it's like, oh, they land in this hospital. Click the banner. Oh, here's the stuff. I don't know if that's being done, but that's a small thing. That's not to fix everything you just said, but it's a small thing to say, well, could we do that at age 14, say, I pick the age.
There was a clinic that I was involved before COVID that started to do that for one specific thing, and I can't remember now if it was CP or what it was.
Yeah.
But they were starting it for that
Yeah.
with the conversation at 14. And then COVID hit, and I don't know what happened, but I think it's critical that we start somewhere. I get calls all the time.
I just wanted to mention also during the question and answer period, I was monitoring the chat function and helping Wendy come up with questions for Tor to ask. There were a lot of comments in there about various organizations like GOT Transitions, and that we'll try to put together afterwards in the document. There were a lot of states that had various programs, some of which seemed like really excellent programs to be looking. So while I would agree, I think, with what Dave said earlier, that there's no one person that has it all right.
Right.
There are some various options out there of what may be working, and it's a matter of how you pull the people together and those ideas in kind of a central area.
Yeah.
To
And
keep them moving forward.
utilize their best practices. When Wendy and I talked before COVID to an organization, she said it took us 8 years to get it perfected. But she knows where they made mistakes. She knows what happened, and those are things we can learn from. And Dr. White gave us the introduction to them. We didn't know them, so we could call up and do a talk with them. And they were very open and honest about where their clinic was and how they got to where they are and how satisfied they are.
Well, I'd like to thank you guys for bringing this group together and having this conversation.
Me too.
And just providing, not just, but providing the information that you're talking about all the resources that people have been
Absolutely.
typing in will be helpful to all of us.
It will be.
Right.
It will be.
Right.
It's so much, I mean, it's a
Absolutely.
great conversation today and so much more.
And we can do that, right,
I think that's right.
Josh?
Yeah.
We're going to be able to pull all the information in the chat together for everybody?
Yeah.
Perfect.
So one thing I want to add on, I think actually the idea of a pulse type document would be great. I think it's actually would help signal to many people in the organization, hey, there's something going on here. We haven't talked much about the receiving docs. And, you know, one of the things that I've run into in my system is they see a child who's got a big issue, and unlike geriatric care, I mean, the geriatric care, they go, oh yeah, they got diabetes and they got COPD and blah, blah, blah. And I've seen that, you know, 1,000 times before, and they're all fine. They hear rare disease and they panic. Like, I've never seen it before, never even heard of it. I can't take care of it. And I think we need to figure out, as part of this solution, how do we get past that for those
Yes.
adult docs
Yeah.
and get them
Yes.
to recognize
Yes.
you are seeing rare disease, you are
Yes.
dealing with this, you may not know it, how can we help you? And so that somehow needs
think
to
that's
be in
right.
this equation.
So I'm going to put on my rare disease hat for a minute, since I sit on the Chloe Barnes Rare Disease Advisory Council for the state. And what I would put forth is that there's no rare disease clinicians out there. There is no fellowship in rare diseases. There's very few people that go in saying, I'm going to be a rare disease clinician, although geneticists come pretty darn close on that.
Close.
Okay.
We think so.
Right. But what happens, at least in primary care, and I will speak for myself, when I moved over to Children's Hospital 20 years ago, I, in essence, became a rare disease doc, because at a place like Children's, you end up seeing tons of patients that have rare diseases. They come out of the NICUs, they come out of the PICUs, they come from the geneticists, family self-refer in. So frequently, especially in my early years there, I would go in to see a patient I'd never seen before, and they would tell me what their child has, and I would look at them like a deer in the headlights and go, tell me about your child and your child's problem, because I haven't heard of this, if I've heard of it all, since medical school. And I learned real rapidly that families loved when you said that, because they knew I knew nothing about it, because there was 9 kids in the country with us. So I think part of where we need to get to, where I'm going with this, for getting clinicians more comfortable, is to have them be willing to want to learn how to take care of these problems. When I went to my practice at Jones, it was because I wanted to care for these, as well as underserved kids and lots of other things. But that was part of why I went. If you've got a clinician out there who doesn't want to take care of the kids, I don't want to transfer the patients to them. But if you got somebody who wants to and says, but I don't know how to do it, that's where the EPIC program you're going to hear about is going to help. But it's also having somebody who's just willing and saying, well, we'll connect you with somebody. And that's that purpose of that warm handoffs that can help you. Because then the person who's been caring for them for 20 years can share the expertise they've learned. And the parents who are experts, because those kids that I saw where there's 9 of them, the parents were the experts, not the clinicians. There was no clinician that had 9 of those kids around.
And social media, I mean, has helped so much. I mean, there's numerous, just in Minnesota alone, there are numerous blogs out there for Minnesota special needs, for Minnesota rare disease, for MLD has their own, where you can go out and learn. So if I can learn from all that, so can other people, so can physicians. Go out and see what parents and physicians are saying. I used to be on a website, a neurologist asked me to be on because there was some misinformation out there. So he was monitoring that, and he called me and he goes, if I correct it, will you put it out there? And I go, then they're going to think I'm smart. And he said, no, will you just please do it, just so that it gets out there correctly. And I used to do it for him. But now it's so much more sophisticated and gets corrected. And I think that's a way. But it's critical that we get the adult doctors to be comfortable, to understand. And the person that is our primary care is a great guy. And he was nervous, and I could tell the way he sat in the chair and wouldn't turn around. And I tapped him on the shoulder, and I go, "Hon, you can look at us. We're okay." And I go, "Here's my MAR, here's my TAR, here's this, here's that." And he goes, "I can do this." And I go, "I knew you could. That's why we came here." And now we've hooked him up with the hematologist. And the two of them are like, when the blood draws are done every Monday, the two of them are talking by 2:00 in the afternoon. What should we do with Maddie now? I mean, that's brilliant. That's brilliant. That's what we need.
I think, and one last thought that I had as we were all talking about the issues that we have encountered with, not saying I don't know how to take care of that or haven't been taught that. Obviously, one person cannot learn all rare diseases, but what is our role as advocates for these young adults with special complex needs to go to ACGME and other education organizations to say, should this be a module? Should this be part of your education as an internist in your residency?
That's good.
Right.
You don't get to opt out just because you never saw it. What is your role as an internist? Because we are allowing
That's a good idea.
and helping children live longer. So on the back end, what's their responsibility and what do we do from an education perspective?
So I will put it again back on my Rare Disease Advisory Council hat and tell you that Erica Barnes, who was one of the other members of our planning committee, who's out of the country right now, and I, as part of a work group we're on for that council, reached out to U of M and to Mayo as the two medical schools in the area, and reached out to internal medicine, med-peds, adult cardiology, adult pulmonology, adult GI, adult hematology, to raise that actual question. We got some interest in saying, yeah, we really do need to kind of think about how we're going to take care of those kids. But the interest was not huge.
No.
So I think that's where we're going to need a lot more people than Eric and myself reaching out to them to make it clear that this is an issue we need you to help your graduates feel comfortable in doing. You know, so maybe every adult cardiologist is not willing to take care of every child with hypoplastic left heart syndrome that makes it at 22, but they have to be more willing to learn what's needed to care for the child so they can take them on.
And I think that's part of the issue that we need to solve here is, I'm not going to solve it today, but as this conversation is, how do you get the attention of those adult specialties to say, these kids are coming your way if you like it or not. You know, time is marching on and they will show up. And in my system, and I'll be honest, if I brought up transitions of care for pediatrics to adult, among our executive group, they'd look at me and have a blank stare in their face. And they'd say, that's a problem. You guys should just solve that on your own. And, you know, I would suspect if you went into most hospital systems, the executive group would do the same thing. And, you know, until we get this to a level of attention that, you know, show that it's a real problem and it needs to have the attention of more than just the pediatricians.
And I think there's opportunities at, you know, medical school, residency, the Minnesota Medical Association, the Minnesota chapter of the AAP. I think it's multi-pronged. It's not just one place. And so.
And it's teaching. We were in an ER offsite, and two doctors came in, and the one was in tears and said, "I don't know where to send you." He was in tears, and he had 20-some years as a pediatrician, but this was the first time that he experienced that. That's not a negative comment, but it's just saying. So then pretty soon, and he knew me, and he was just so upset because he didn't know what to do. He sent the ambulance away because he didn't know where he was going to send us. Then the next doctor came in, it was on the next shift, and he goes, "I don't know you, but I heard about her and I figured this all out. I don't know what to do. Our healthcare system's a mess." And here's two people that were enlightened just by this. That's what we have to do. We have to get all levels from education. The one doctor that night was so upset that he called the dean of the med school and said, "What is going on?" And then they called bone marrow transplant and said, "What is going on?" And so more and more people need to be enlightened. When I had the people come to my home, 2 doctors were on the front porch in tears because they knew us very well but did not know what it was like, what we lived like, what our house was like, what the care that we were giving at home. They were enlightened, and it changed, how they did things from then on. And those congressmen, we got a 10% reduction in the parental fee that year because they didn't know what they were voting on. They didn't know. And when they saw it firsthand, they're like, whoa. And when they saw the prices of all the things laid out there, I didn't know if I was telling the truth, but I was. And it worked because they were enlightened, and that's what we have to do.
Right.
So I think this goes to show that our work is not done, and that this is just the tip of the iceberg in terms of tackling this really complicated problem. I think we have a quick poll to do of our audience members.
Well, I think it's probably better just to open it up to chat and
Okay.
other people suggest. We've had a lot of good suggestions, but now let's let the chat
Okay.
kind of fill up with those suggestions, and then we'll compile.
Sounds good. Well, we will allow the chat to flourish with other ideas and thoughts. And suffice to say, as a group of folks that came together, we started this conversation about a year ago. Sheldon and I, and Wendy Burkhorst from Minnesota Department of Health, and Erica Barnes from the Chloe Barnes Rare Disease Council Advisory Council. And we had a conversation much like this of something has to change. Where do we start? And we settled on, we have to start having a conversation and really breaking down the silos. And we went through a lot of iterations of who should all be here. And we are so thankful for all of the folks here on the panel who are giving their expertise and insight and wisdom and time to this very important issue. There are many, many more layers of this conversation that needs to happen. Certainly, as I listen to everyone talk today, I think the thing that comes through is this conversation needs to start. It needs to be a snowball. We need to get more layers involved as well, care coordinators and social workers and legislators, and really come together and have poignant conversations about what are the next steps. And Sheldon, do you have other thoughts and insight from today?
Yeah, first of all, I want to thank everybody for participating in this. This has been a journey I've been on over the last 15 to 20 years, starting with setting up a medical home program at our hospital for our special needs kids, for our complex of the complex, the ones where kind of the program that if you're a parent, you didn't want your child to be part of because they would mean they had such complex needs. And then learning how to care for them, and then starting to deal with transitions and trying to figure out how we can do it. So this is great. It's a start. And there were some things that I heard that I really loved. I really loved, Kurt, your comment about what you started to do beforehand, line before the pandemic, and realize now I got to go back and kind of follow up about whatever partner group that was, about, okay, let's see how we can work together to really arrange to help with that transition. I love the comment about making the right decision, the easy decision. We had asked the panelists all before this even started to talk about what their ideal transition would be. And I think in essence, it boils down to this, is that we know what the right thing is. The right thing is to make sure that wherever that young adult lands is a good spot for them and a good spot for their family, and they're going to get the care they need. And it goes back to whether it's because the child has asthma and they got to go to someplace that's going to take care of their asthma, or autism, or they have a 9Q- deletion, of which there's 2 in the state, and we got to help figure out where they're going to be seen. I don't know if there's a 9Q- deletion. I think
Usually it's 9P, but that's okay.
that's okay. I think I had the 9P in my but that making the right decision and making the easy one. I love about partnering with various groups. You were talking about that, Kurt. Learning from other states and other programs, what's out there is really important. Pat's comment about, all right, we've heard great ideas, we've got to do something. And that's real appropriate, and it's going to be where, in my mind, all the people at this table are great to discuss and come up with ideas. We also have to make sure that the people that are at leadership levels above us are also hearing the message, because as I've learned for a long time, they're the ones who are ultimately going to make it. That advocacy to get them to listen is important. You know, Nate may be the medical director for state Medicaid, but he's got a boss he reports to. So we got to, you know, get to that boss. And Nancy's got high leadership at UnitedHealth Group, and there's higher leadership that she's got to communicate with. And it's for the same for all of us. We got to figure out how to get that message across. But this is a great starting place. I love, we talked about doing a word cloud at the end and having people just put a word in what it left them with, but we don't need to because Pat said it. And you said you were energized.
Yeah.
And that's what we hoped would be the response from everybody, is that they're energized to go back and talk about the things you've done and carry on this discussion. So even though I'm winding down my career, I retire in 2 weeks. And I'm very glad that people like Tori are going to really be picking this up to keep running with it. And Nancy will pull me in and others will, but it's a great place, and we're further along now than we were 3 hours ago and that we were 20 years ago when I started really on my journey with this. So thank you. I want to thank you all for participating, and all the audience members who sent in all of your wonderful comments, only a few of which we were able to really tackle, but wonderful comments and statements made and questions raised in SIR. So thank you.
Yes, I can't say thank you enough. A few things of where we go from here. So there was some conversation about how do we really educate our adult primary care colleagues. And I am working with the Minnesota Medical Association on a Project ECHO, which will tackle this exact issue, where we will bring cases of real patients struggling through transition, talk about it as a group virtually on Mondays, starting July 18th, every other Monday. And we'll have experts there to really talk about some of the nuances of caring for this population, and also learn from everyone else, because as we've learned today, there is no expert in transition or in the care of medically complex people, because every patient is an individual, and every environment in which a patient lives is an individual, and it looks different if you're in St. Cloud or if you're in St. Paul or somewhere else, North Dakota. But we really hope to tackle that issue in that way over the next year or so. We have a grant to support that work. We will be collaborating as a planning committee that brought this to figure out how do we continue this conversation and where does it live. And I hope some folks have ideas in the chat of where this lives as well. We also have a survey to get information from all the attendees about the experience today and what they wish for the future and how we can do this better for the future. There's a QR code that will be on your screen that you can fill out. Otherwise, it'll come by email, and you can fill that out. There is a checkbox on that summary if you want to stay involved and hear about updates from this. The event was also recorded, and we'll be sending that out. So share widely with those people that you work with and the people that you work for, so that we can continue this conversation forward. I want to give a special thanks to the planning committee. We had a wonderful videographer, Ben, who was here today. The planning committee, of course, was myself, Dr. Berkowitz, Wendy Berghorst from the Minnesota Department of Health, and Erica Barnes, who's streaming, I think, from France. And then Josh was our wonderful CME coordinator here at Gillette, who really did all of the nuts and bolts and kept us on task and got everyone here.
Great.
So special thanks to Josh. And I just want to close with saying that together, we really can make a difference in transforming this pediatric to adult healthcare transition into something amazing. I cannot thank you enough for joining us, and this is just the beginning. Thank you so much.